So good morning, and I am very, very happy to be here. Today we're going to start this off by asking a question. Did Princess Diana have to die? The book called Death of a Princess asked that question several years ago. And I'm not asking it from a conspiracy point of view, I'm really asking it from a medical point of view. And let's look at the facts. So in August of 1997 in Paris, France, at about 12:30 in the morning, a car carrying Princess Diana struck a concrete pillar. It did so at approximately 100 kilometers per hour, stopped almost instantly, killing 2 of the 4 passengers immediately. The bodyguard in the right passenger seat, he survived. He had his seatbelt. Diana had no seatbelt. She survived initially, but her wounds were extensive. So let's look at the timeline. If you look at the far left of that line there, the crash occurred at 12:25 in the morning. Go to the top line now. Here's what's interesting. From the time the crash occurred to the time Diana arrived at the hospital was 1 hour and 45 minutes. Okay? And the accident occurred 6.15 kilometers from a very large teaching hospital with a really good trauma center. Now that's only 4 miles. It's a little less than 4 miles in the middle of the night when there's no traffic. And it took 1 hour and 45 minutes to get her to the hospital. Why did that happen? So when we go to the timeline there in the middle, 12:25 in the morning, that's when the crash occurred. About 15 minutes after that, you see the SAMU, that's the equivalent of the French ambulance service. It arrives with an onboard physician who treats Diana at the site for 50 minutes. They then load her into the ambulance, and it takes about 40 to 45 minutes to go just under 4 miles to the hospital. Again, in the middle of the night when there's no traffic. In other words, they drove at, quote unquote, a snail's pace. She arrived in the hospital at 2:10 in the morning, and she was declared dead at 4. The source of her injury was a single lesion. It's where some blood vessels come out of the lungs and where they enter back into the heart. There was a partial tear of those blood vessels as they entered the heart. And if there had been a full rupture of those blood vessels, she would have died in a few minutes. But a partial rupture is eminently survivable if, and only if, you make it to an operating room reasonably fast. Okay? Now, the French didn't do anything wrong by their protocols. That's how they do things. And that's really the controversial part here. In the United States, we treat very differently. We do something called scope and run. When our ambulances get there, they check them out really fast, throw them in the ambulance, and get them to the nearest ED as fast as they can. In France, they do extensive on-site treatment. And both systems have advantages and drawbacks. And to say the least, the French were not too happy when that book came out, sort of questioning how they treated Diana. They actually threatened to sue the authors. And the author said, we weren't trying to say that the United States system was necessarily better. We were just hypothesizing that a different approach for trauma might be better. Okay, well, let's see what the data shows. Here's system performance by nation for trauma. On the vertical axis there, you see the mortality rate. So obviously, the lower the number, the better. The lower the number, the less people are dying from trauma. In the United States, we do better than at least the 3 countries that are listed there, Germany, Great Britain, and France. France is a little over twice as high as we are. Which really brings up a question. Healthcare in the US is broken. You hear this all the time. And assertions regarding US healthcare is that it costs more, which is true. It delivers less, well, that depends. And it is inequitably applied, and that may also be true. But are all of these assertions true? Well, even if they were all generally true, I'll tell you this, I'd rather have my trauma in the United States than I would in Europe, generally speaking. So we'll call that an introduction. Today we are going to go through this. We're going to talk about modern medicine. Yeah, it has its challenges, but frankly, it's the best the world has ever seen. I'm going to show you some stuff on that. We're going to talk about why it's not financially sustainable, though. It really isn't, especially in the United States. Then we're going to talk about the PPACA, the Patient Protection and Affordable Care Act, or sometimes called the ACA, or Affordable Care Act, or Obamacare. a term I used to not use, but he did in the debates with Mitt Romney say that he was okay with that term. So PPACA, ACA, Obamacare are synonymous. We're also going to talk about the financial challenge that's giving us in healthcare, and then we're going to talk about some of the things that are going to face healthcare in the next 5 to 10 years. There is, make no mistake, a sea change coming in healthcare. It ain't going to be the same in the next 10 years as it's been in the last 30. I will guarantee you that. So let's talk about that first line item there, modern medicine, the best ever. So the emergence of modern medicine, well, arguably mid to late 1800s. A very important report called the Flexner Report came out. It basically said, man, medical education is terrible, you got to change it. So they did, had strict requirements for how we licensed physicians and other healthcare practitioners after that. Actually introduced the fact that maybe we should base some of what we do on science, like the germ theory. And then hospitals were icky, terrible, dirty places around 1900, early 1900s. And hospitals started getting consistently better starting in the early to mid 1900s. So that by 1912, we reached the Great Divide. For the first time in human history, a random patient with a random disease consulting a doctor chosen at random stands a better than 50-50 chance of benefiting from the encounter. So that's kind of interesting. Before 1900, nobody used doctors. They were horribly trained, didn't know what they were doing, but that did start to change over time. So let's look at what some of those miracles look like. On the x-axis here, the horizontal axis, we have time in years, starting with 1900 and going to 2000. On the vertical axis, we have life expectancy. So a higher number is better in this particular graph. And you can see that in 1900, the far left of the graph, the life expectancy was approximately 50 years. And then over the course of the next 60 years, from 1900 to 1960, that went up by 20. From an average age of 50 to an average age of 70. Why? Public health. Okay? Clean water, clean food, and especially the control of epidemic infectious disease, which in our day we can't even relate to. We don't have epidemics now like we did back then. And then that whole thing with public health flattened out in the 60s. And then we had another period of gain, about 7 years, from an average age of 70 to about an average age of 77, which is where it stands today. The average age of life expectancy today is about 77 years old. And what did those last 7 years of gain come from? Well, that's really because healthcare really is the best the world has seen. Let me give you some examples of that. Mortality from heart disease generally has decreased by 56% over the last 50 to 60 years. Same with stroke. Since 1950, a decrease in mortality of 70%. So while the early gains were public health, the late gains have been the result of treatment of specific disease. Okay? And let's compare our performance in the United States to performance in other countries that practice Western-style medicine. Here's mortality rate from heart attack. Again, a lower number is better, and you can see that we're 6.5%, and Germany, Britain, and France are all significantly higher than we are. What if you have a premature infant? Where would you want to have your premature infant? A 1,500-gram infant is a tiny little infant, okay? And again, this is mortality. A lower number is better. In the United States, we do very well with premature infants. Certainly, I'd rather have my premature infant here than, say, in the United Kingdom, which has double the mortality. So yeah, healthcare may be broken in the US, arguably, but I would rather have my trauma, my heart attack, or my premature infant. I showed you that data. I didn't show you data on cancer, kidney failure, or liver failure. Those last two, kidney and liver failure, needing transplant. Numbers are very similar. You have a much better chance of surviving cancer, or if you need a transplant of a major organ in this country. Why? Because in the United States of America, we do very well at something called rescue care. Some people call that tertiary care, quaternary care. We put a lot of effort into saving the very sick, the very, very critically ill. That gives us 2 or 3 things: better access to technology. We have a lot less rationing in this country. Other countries actually do ration a lot more than we do. And then finally, easy access to doctors who are subspecialists as opposed to generalists, all right? So I would like to suggest that healthcare in the United States isn't actually broken. Okay, the potential of healthcare is way up here. If healthcare were broken, we'd be way down here. We're somewhere in between. You know, we routinely do perform miracles, but we haven't reached our potential. And that said, leads us to point number 2. Maybe the best ever, but it is absolutely not financially sustainable. And I'm going to talk to you a little bit about variation in delivery of healthcare as a driver of that non-sustainability. So when people say that the US is expensive or that healthcare is expensive, they're usually talking about one of 2 ways of looking at it. And those ways are depicted on these 2 graphs. Let's take the line at the top, which is, I believe, yellow. I hope you can see that, the line at the top. And the vertical axis on the left side, percent of our gross domestic product. Gross domestic product is all the goods and services produced in the United States of America. The percent of our GDP given to healthcare. And you can see that in 1960, which is far left of the horizontal axis there, adjusted to $2005, it was about 5%. And it's been going up inexorably, inexorably, inexorably. It's just been going up and up and up. But you can see that it flattened. Look at that one part of the graph right there. From 1993 to 2000, it flattened, just for a 7-year period. And we're going to come back to that. You're going to see that many, many times because that has not gone unnoticed. For those of you who are familiar with healthcare or know anything about healthcare, that was the time when commercial insurance sort of flipped the way things were done, and it was called the managed care era. And doctors hated it, and hospitals hated it, and patients hated it, and it was spewed after 5 to 10 years. But it certainly has not gone unnoticed that it flattened this curve. Now, when people say that the United States is expensive compared to other countries, they don't usually use this curve, gross domestic product, because every other country that practices Western-style medicine, their curve looks about the same. Okay? It's a little bit downshifted, but the slope is about the same. When people say we're expensive, they're talking about the bottom curve. This is the per capita cost. This is the dollars per person in the United States. And when you compare us to other countries, we're the yellow line. Compare us here to Sweden, United Kingdom, Germany, Canada. We're 2 to 3 times higher per person. In fact, the closest second that I know of is Switzerland, and we're 50% higher than Switzerland in the United States. So yeah, we do spend more money, certainly on a per person basis, than any other country. Now, there's lots of reasons for that, but I just want to talk about one of them that's actually underappreciated. We're going to talk about variation in the delivery of healthcare, and we're going to divide this into 2 main ways of looking at it, if you will. One is what I call macro variation. You see this graphic on the upper left-hand corner. It's a very famous graphic in the patient safety and in the healthcare economic world. And I'm going to get to that in a little bit, but that shows variation between regions of the United States. So that's what I call macro variation. And then we're going to get into micro variation. We're going to look at any hospital in the United States and compare physicians who do the same thing and how they deliver care. And you're going to find that care varies tremendously, even among a given group of physicians in a given hospital. Okay? And we're going to talk about why that is less than ideal. So let's start with macro variation. Let's start with this regional variation here on the left side. And we're going to have to go to a gentleman by the name of John Wenberg. Now, John Wenberg's guy graduated in the 60s, MD, MPH, Masters in Public Health. Most medical doctors, I'm an MD, MBA, most medical doctors don't know much about what we call population health. We're not trained to think about populations of people. We're trained to think about individual episodes of acute care, one person at a time. But John Wenberg had this MPH, and he was sort of working in Vermont. He was trying to help implement LBJ's Great Society in the 1960s to make sure that everybody had the freedom to access health care. And so he started studying populations in that particular part of the country. So he was in, you see in the lower left-hand corner there, he was in a place called Waterbury Center. And he was studying how many kids, actually, or how many people by the age of 15 had tonsillectomy. And he found out that less than 20%. Now, back in those days, they took tonsils out for almost any reason. Tonsillectomies aren't so common anymore, but way back then, they did, you got an infected tonsil, they took it out. Okay, we don't do that anymore. So tonsillectomy, Waterbury Center, less than 20% by the age of 15. He then walked 1,000 yards north, and he goes to the Stowe School District, and he finds out, same thing, tonsillectomy, but now prevalence is over 60%. It's 3 times as much. He couldn't figure that out. Populations weren't any different. They were right next to each other. People weren't any different. There was no socioeconomic difference, nothing he could find. And then he started studying other conditions other than tonsillectomy, and you see the quote to the right on the bottom there. It wasn't just one procedure that varied. Virtually everything did, and it led to this graphic right here. Very famous one in the, again, healthcare economics literature that's from the Dartmouth Atlas. This is Medicare spending per beneficiary, 2005. Apparently, according to Wenberg, the United States divides naturally into about 206 regions around providers of care. So Loma Linda, for example, is a provider of care. And you can imagine a region around Loma Linda. You can imagine a region around Cedars-Sinai and UCLA in Los Angeles, maybe the Mayo Clinic in Rochester, Minnesota. There's 206 of these regions. So he started comparing costs of care in these regions, and he found tremendous variation. Let's go to one of the highest spending regions in the United States, good old McAllen, Texas. On the far southern tip of Texas, you see there at the bottom. McAllen, Texas spends, in 2005 anyway, was spending about $14,000 per person per year, Medicare, okay? Now let's compare that to a place that's a low spending region, where I was born, in where I grew up, in Central California. More cows than people, sparsely populated, spending about half as much money as McAllen, Texas. But here's the kicker there on the bottom, with no measurable difference in outcomes. So now you've got a payer, in this case the United States government, spending twice as much in this region as this region with no discernible benefit for their money. Now if you were doing that, if you were paying 2 people to do the same thing and paying one twice as much as the other, and you couldn't see any benefit, you wouldn't keep doing it. You see what I mean? Okay. So let's try and talk about that a little bit. Why? I mean, what's going on here? Causes, ramifications. First of all, people said, is it real? Is this regional variation actually occurring? And a lot of people have studied it, and I don't think anybody argues about that. I mean, they might divide the regions differently, but everybody sees regional variation. So that argument has gone by the wayside, and everybody agrees, yes, there is regional variation. The next thing, though, do we know the causes? Boy, that's argued. They're still arguing about that. They've been arguing about that for years. It could be, for instance, that prices are higher in McAllen, Texas than they are in Central California. It could be that people are sicker in McAllen, Texas than they are in Central California. It could be socioeconomic factors. Maybe people are poorer or less educated or whatever in McAllen, Texas. Well, Wenberg and the boys and girls that work for him say, no, we've corrected, doing all of our statistical magic, and we've corrected for all that. And here's what the cause is. I've written all that gobbledygook there in the bottom right, but I'm just going to tell it to you in English. He basically says it's driven by supply. He said, you take any region and you give them more doctors and more hospital beds, it will cost more money for healthcare, irregardless of the status, the health status, the socioeconomic status. You just give them more doctors, you give them more hospital beds, it will cost more money. All right, in other words, it's driven by supply. The supply of doctors and beds pulls demand with it. Now, do you think that that's something that doctors and hospitals like to hear? It's really not something they'd like to hear, because they'd like to believe that that's not the case at all. In fact, the American Hospital Association disliked that so much that they did their own study. Here's the AHA study. First of all, they said that 55%, you see the big pink region there, 55% of the variation is unexplainable by the data. Just write it off. We don't even know what's causing it. Of the stuff that's left, okay, of the 45% that's left, about a little over half of that, actually, 24%, can be explained by the health status. In other words, it's more money because these patients in these regions are actually sicker. And then look what they said about supply, 2%. Now that's completely opposite from this study. You couldn't have 2 studies that were more opposite. And it's been debated for years, and people weren't sure who is right. I don't think anybody knows for sure, but I will tell you this. The federal government believes that the Dartmouth Atlas is right. The federal government believes the explanation from these guys here, okay? And that's a very, very key thing for healthcare, because if you actually believe that that's true, then what are you going to do to try and change that? You have to try and change the incentives. If the Republicans were in office, they would use market forces. They would try to use the market to change the incentives, but they lost. The Democrats won. And the Democrats are going to do something very different. They're going to change the way they pay for health care. They're going to just put what we call a cap. They're just going to say, Loma, Linda, or whomever, here's your money for the year, go do. And if we can stay below that, we make some money. If we can't stay below that in our costs, then we lose money. And we're going to come back to that a lot, because that is a paradigm shift. But it's the same thing that happened in the 90s, except that the commercial payers did it to us back then. Now it's going to be the government that moves that way. And everybody's looking at this curve and they say, hey, it worked in the 90s. We flattened the curve. Yeah, everybody hated it and they spewed it, but we did flatten the curve, and so we're going to go back there. Okay, that's the thought. All right, now let's talk about micro variation. Yeah, there's variation between regions, but there's also a lot of variation between physicians. If you come to a hospital, let's say you have a pneumonia, and let's say you go to a hospital that's a small to moderate sized hospital, and they've got 5 different doctors called hospitalists that can treat you with pneumonia. They could treat your pneumonia. You would say, well, I probably would get pretty similar care from each one of those doctors. And there's a lot of research that has shown, no, you wouldn't. You actually would get a highly variable approach from a lot of those doctors. There is a well-documented massive variation in practice beyond the level of even the remote possibility that all are receiving remote care. If there's 5 different approaches from 5 different people to the same thing, they can't all be right. That's really what that's saying. Okay, now why? Why? Well, 3 questions actually arise from that. First of all, why so much variation? Number 2, why is variation bad? Maybe it's not such a big deal. Okay, yeah, there's some variation out there, but it's no big deal. Let it happen. And then what can we do about it? I'm going to go after those first 2 questions now, and then if we have time at the end, I'll describe that last question a little bit. So let's talk about the first one. Why so much variation? Well, it's an interaction of a couple forces in a system, which we call, the system we're in now is fee for service. Everything a physician does, they can actually bill for, okay? That's not the system we're going to be going to. So you have that fee for service system that we're in right now, and then it's something called the craft of medicine. Physicians are given tremendous autonomy to do what they want. Nobody gets in their way, and in fact, we pick people that are very autonomous thinkers, and then we put them in medical school and we teach them to think autonomously. And then they get out of medical school and guess what? They're very autonomous, right? So you get that autonomy and you add that to complexity. The healthcare has become very, very complex. World Health Organization lists 13,000 diseases and conditions. 13,000 diseases out there, okay? 6,000 medications that a doctor can find in an average hospital formulary, 4,000 procedures, 2,000 or 3,000 laboratory tests, right? So when you add that autonomy with that complexity, it's not that variation in practice might occur. Variation under those circumstances is actually downright inevitable. Now, let's ask the next question. Why is variation bad? Well, it's not all bad. There's some parts of it that are good, but I don't have time for that. Let's look at the bad side of variation. First of all, and I'm a patient safety officer. I'm the vice president for safety at Loma Linda, so I'm worried about safe patient care. And I will tell you right now, as the patient safety officer, variation adds complexity, and anything that becomes more complex becomes less reproducible and less safe. That's point number 1. I'm going to skip point number 2, and I'm going to go to point number 3, which is more apropos to this talk. Variation adds cost. And so a lot of that cost that you're seeing that I've talked about in the last 10, 15 minutes, this is one of the contributors. There's several contributors. I just chose to talk about this one because not a lot of people think about it or know about it. Variation does add cost. All right, so that gives you a little bit of a background and an underpinning. Let's talk now about PPACA, or ACA, PPACA, Obamacare, all synonymous, all right? Because Obamacare is trying to solve some of these issues, and let's look at what it is and what it's trying to do, and we'll look at some of the ramifications. Now, you all sort of know some of these ramifications if you read newspapers or if you have some kind of a device, where you periodically punch into the news and try and figure out what's going on. This has been in the news a lot, as you know, lately. So we're going to look at some of this. Two things driving healthcare reform, make no mistake. Number one, and we've been discussing this for the last 15, 20 minutes, cost. Healthcare costs a lot, and they're pulling out their hair trying to figure out how to control the cost of healthcare. But the other thing is coverage. How do we take 50 million people in the United States that don't have insurance and cover most of them? Obamacare was never intended to cover all of them, most of them. So let's take those one at a time. The first thing that happened is that PPACA, Obamacare, was passed into law in 2010 and was immediately challenged in the courts to the point where it went to the Supreme Court. And the Supreme Court really had three major decisions coming out of there. First was the one that you probably have all heard about, the individual mandate. Can the federal government really force individuals to purchase health care insurance? And the United States Supreme Court said, yes, they can, but not under something called the Commerce Clause. You can do it, but you have to call it what it is. You have to call it a tax. All right, so they okayed it, but with that provision. Can't do it with something called the Commerce Clause, which we won't get into. You have to call it a tax. Right? Number two, the Medicaid expansion. One of the ways to take those 50 million people that are uninsured is to take the poorest of the poor, expand a program called Medicaid, which was invented at least partially to help fund the poor, and that way we can take them and put them into Medicaid. And so that was also challenged. Is the ACA's Medicaid expansion a violation of states' rights? And this is where the Obamacare Act lost just a little bit of ground, but important, actually. Because the federal government, the Supreme Court actually said, yeah, this is okay, Medicaid expansion was upheld, but you can't force the states. What the federal government was doing was they were coming to the states and saying, look, we're going to expand Medicaid. And if you don't do it, we're going to pull all the Medicaid that you already have. Now that would be tens of millions of dollars for the vast majority of states, a lot of money. They couldn't afford that. And so the Supreme Court said, no, you can't do that. That's like holding a gun to their head and saying choose. Okay? So that actually allowed the states a lot more leeway to do what they wanted with the Medicaid expansion. And we'll come to that in the next slide or two, because that's actually important. And finally, severability. Should the remainder of the ACA stand if a portion of it was struck down? And they said, yeah, we struck down a little bit of it, but not much, so the law can go forward. All right, so what in a nutshell was the Affordable Care Act? Remember, the Affordable Care Act was signed into law 2010, went to the Supreme Court, that's what I just showed you on the previous slide, survived the Supreme Court, and is now going forward. Well, PPACA, Obamacare, was simply about coverage. It's about insurance. How do we take 50 million people that currently aren't insured and insure most of them? That's what its whole purpose was. And here's how it was originally construed to work, right here. If it had gone as planned, right, a big if it had gone as planned, it would have covered about 32 of those 50 million people. Let's look at the bottom line there. 17 of those 32 would have been through the Medicaid expansion, which again, Medicaid covering the poorest of the poor. And that line is important there, those numbers. From 0 to 133% of the federal poverty level would have been, Medicaid would have been available to them, okay? The big thing, though, is that the Supreme Court now allows states to make the choice, like I told you before, of whether they want to expand Medicaid. And of the 50 states in the United States, I think 20 of them have chosen not to do that. So we're not going to get 17 million newly covered people because a bunch of the states have chosen not to do that. So the numbers have been downgraded some, and I'm hearing anywhere from like 9 to 11 million, something like that, assuming that the law continues to go forward and enroll these people. Now the next group of people who aren't quite as poor as 133% and lower, above 133% all the way to 400% of the federal poverty level, the healthcare exchanges. Okay, anybody heard healthcare exchange recently in the news? Okay, that's been popping up recently. It's caused quite a bit of controversy. People eligible for the healthcare exchanges. People eligible for the healthcare exchanges, again, you have to be somewhere between 133% up to 400% of the of the federal poverty level, these people, I lost my train of thought. Let me go backwards now. So this was supposed to be ready by October of last year, remember? And was it ready? Okay, on day one of Go Live, was it ready? It was not. Why wasn't it ready? Well, let me show you why. This is why it wasn't ready. Because it's complex. It's very complex. And this particular diagram doesn't do justice to its complexity. But if you look at the green stuff in the upper left, those are all the federal departments that have to be hooked into this. So you have Health and Human Services, the IRS, the Treasury, Social Security. And all those departments have their own computer systems. They're very old computer systems. They don't talk to each other. They need to get information from all those computer systems into a central hub, hook those up with the states. The states are in the blue in the upper right. On the bottom, we have all the insurance companies. And then we have all this stuff that's built to bring all of those things together and make it all communicate seamlessly. It was supposed to be built so that somebody like yourself or me could theoretically get on there, punch in our name, punch in all the pertinent data, and it would tell us exactly where we fit here. You know, are you eligible for Medicaid? Are you eligible for the exchanges? And you would get some benefits because you're between 133 and 400% of the poverty level. It was supposed to do all of that, but it didn't. It blew up. Why? Because they underestimated the complexity. They put the wrong people on it who didn't know what they were doing, and they didn't even come close. Okay? So that's really what happened. Now, the ramifications of this, just a few things before I go on. That 400% cutoff is a big deal. You know, you've been hearing a couple things. Several things, but let's just talk about a couple things. Of the 50 million uninsured people, a bunch of those are young people who don't think they're ever going to get sick. And they choose not to buy insurance. And now they're being mandated to do so, right? That's the mandate. You have to buy insurance. And so they go on this exchange, and especially if they're above the 400% poverty level, they find it's very expensive. Very, very expensive for them to do that. So they're going to choose not to do it. A lot of them are opting out because the penalty for not doing it is way less than actually doing it. So that's point number one. Point number two, you've heard that a lot of people who had insurance now are losing their insurance and being forced to go on the exchange. These are people who, you know, went out into the private market. They didn't have employee insurance. They bought their own insurance. But that insurance under Obamacare has to be stopped because it doesn't meet minimum standards that Obamacare demands that all insurance meets now. So this insurance is being dropped by the insurance companies, and they get back on the exchange to buy on the exchange. But again, they're above the 400%, so they get no support from the government. And they find out what? It's very, very expensive. That's what they're finding out. It's way more expensive than what they had before. So that 400% is an important number. And people who are below that are going to perceive that they probably are getting a pretty good deal when they're buying insurance. But people who are above that, who go onto the exchange, are probably not going to perceive that they're getting a particularly good deal. So there's going to be perception of wins and perception of loss on this, depending on where you are. All right, with that in mind, though, what did professionals sort of think about Obamacare when it came out? Well, there was a lot of opinion, but when it comes to cost, this is a guy out of Stanford, Elaine Enthoven out of Stanford. He's a healthcare economist. He lamented the current state of the healthcare system, but that last line is the important one. The current reform bill, that's the Affordable Care Act, what we're talking about, Obamacare. He's saying this Obamacare thing does practically nothing to slow healthcare expenditures. Okay? He said, man, this is going to cost us a fortune. And a lot of people were saying that after Obamacare came out. Now, here's the thing that a lot of people miss, though. So we've got PPACA. I'm just pretending like that's the PPACA legislation there in the upper left. There was language in PPACA really buried. Remember, PPACA was a couple thousand pages, right? But there was some language in there that said by 2012. Now, remember, PPACA came out in 2010. And there's language in there that's saying by 2012, you have to write some legislation around something called shared savings. And believe it or not, you never hear about this, but this, more than Obamacare, this legislation is making hospitals like Loma turn backflips, trying to figure out what we're going to do, because this is the one that really changes the payment paradigm. This isn't trying to encourage us. They're changing the incentives through this legislation, trying to encourage the Loma Lindas and other hospitals and healthcare systems of the world to create a new healthcare entity. They call it an accountable care organization. Now, what do I mean by that? Now, I give a lecture not unlike this one to medical students. And I love to ask medical students a question. I say, haven't we always been held accountable for our healthcare outcomes? And they look at me with a blank stare. They really aren't sure. And I say the answer to that is actually no. I mean, in the good old days, we used to be able to treat a patient. We could make a mistake on that patient, do whatever we had to do to correct that mistake, bill for both of those things, bill for the mistake and bill for the correction, and get money and never be held responsible for the mistake. Okay? That happened a lot in healthcare. That's what they're trying to get rid of, okay, at least partially. They're trying to make us accountable for the healthcare outcomes and the experience of the patient. Line number 2 there, improving the health of populations. If you want to make a physician nervous, give him hives and get him scratching, all right? You sneak up behind him and you say, population health, because they have no idea what it is. They have no idea how to affect it, and they're worried about it because this legislation is trying to drive us away from thinking simply about individual episodes of acute care and more about how do we make the population of San Bernardino County healthier. All right, now that's a big paradigm shift. How on earth would you do that? How would you even measure it? What is population health? Now, if you stick around in this lecture, you'll know more about population health than 99.9% of the doctors, because I've got 2 slides that basically explains it towards the end that all physicians should know about. And they all want us to do this while at the same time reducing the cost of healthcare. So measurably better outcomes for measurably less dollars. That's what they're trying to achieve here. And it's all on a continuum, taking us from the fee-for-service world we've been in for a long time to the capitated world. Remember, fee-for-service, we do it, we bill for it, we get paid for it. Capitation, the payer says, here's a chunk of money, it's going to last you the whole year, you do whatever you do, and hopefully you'll have some money left at the end of the year. Totally different. Changes the incentives, changes the way we practice medicine. But that's where we're going, and make no mistake, we're thinking that we'll be totally capitated in California within 5 years. That's what we're thinking. And it's kind of hard to get used to that. Okay, so what kind of financial challenges is that putting on hospitals and healthcare providers generally? It's actually huge. And this is the thing that's making us turn backflips right now. About 4 things are happening. Well, 4 major things with lots of little things under the big things. First of all, we're just getting less money. We can't charge as much as we used to. That growth in what we used to charge is going down because the federal and state, you know, their budgets are constrained. And here's the thing. We've always lost, all healthcare providers, with few exceptions, have always lost a lot of money from government payers, be it Medicare or Medicaid. We lose tons of money. We lose tens of millions of dollars on that at Loma Linda. So how have we been able to make a bottom line and a profit at the end of the day? We basically squeeze the commercial payers, the private payers. You know, they would give us double-digit increases every year to backfill all the money we were losing from the public payers. Well, a few years ago, because of Obamacare and other constraints, the commercial payers dug their heels in, and they're not doing that anymore. Okay? So at the same time, though, as we move to the right, our costs keep going up. We're still having to go out there and compete for hard-to-find labor, nurses. There's a nursing shortage. There's a shortage of every healthcare worker out there. There's just not enough of them around. So the price for them keeps going up. We're being pushed to buy a lot of information technology, way more than in days gone by. And then a big point here. I'm a baby boomer. There's probably a few of you in the audience that are baby boomers. There's 75 million of us. We're turning 65 at a rate of 7,000 to 10,000 per day, okay? And there's a big chunk of us where that's all happening at one time. So the average age of the population is actually going up because of that. And the other thing too, that baby boom population shifts the payer mix as we go from, you know, being on commercial insurance before age 65 to being on a public payer, Medicare, after the age of 65. It shifts from good payers to bad payers. And then the 4th thing on the bottom right there, as we get older, all at the same time, we start getting expensive, because we're going to see in slides to come up, the big 600-pound gorilla, or at least one of them, when it comes to cost containment, is elderly people with chronic conditions. Just stick that in your head. Elderly people with chronic conditions cost an inordinate amount of money in healthcare, a huge amount of money. And I'll show you a slide on that a little bit later. So with that in mind, let's get to the last bullet point here. I think we're making good time. Measurably better dollars, or measurably better outcomes, I should say, for measurably less dollars. That's what it comes down to. We're going to be held accountable for our outcomes. We're going to have to measure those. And we're going to have to do all this for less dollars than we've been doing in the past. And it's not going to be easy. It's really going to be hard to protect the bottom line through all of this. Now, this is a way of looking at costs that I found really, really interesting. You see in the bottom right there, every organization, I don't care if you work in a hospital or any organization, they're always worried about how much it costs per year to do whatever they do. And I was at a hospital system in Utah called Intermountain Health, a very preeminent system of hospitals in Utah. And their CFO, their chief financial officer, gave us a lecture, and he was talking about cost. He said, we like to break that into 3 different ratios. And you can see them on the top there. I'm going to describe each one of these. They're actually very straightforward. Encounters per year times processes per encounter times cost per process. Okay? And if you do the math, and you cancel similar terms, you see that comes to cost per year. So it's just a way of studying cost over the course of the year by 3 different ratios that you see at the top. So let's take those ratios one at a time. Encounters per year. What is an encounter? It's the process of a patient coming to a provider, receiving services, and leaving. So at Loma Linda University Medical Center, we have approximately 33,000 patient encounters per year, 33,000 admissions to the hospital. That's what we mean by an encounter. Encounter can be inpatient, it can be outpatient, it can be a nursing home, it can be a rehab facility, whatever. That's just an encounter. Okay? Now, how do we make money at Loma Linda right now? By having more and more encounters of the kinds of patients that pay well. So what I want at Loma Linda right now is lots and lots of admissions of people who have commercial insurance and who need a procedure. That's what butters our financial bread at Loma Linda. Okay? But they're going to change the incentives on us pretty soon. When they capitate us, all those encounters, I don't get money for each of those encounters. I just have a flat rate of money I get for the year. So every encounter under that circumstance represents what? It's an expense, see? So it's a total shift. It's a total different way of thinking. So in the future, when I'm capitated, and now I have to control encounters, because I don't want more encounters, now I want less encounters, how would I do that? Well, here's the way not to do it. This is one of the great fallacies that you see out there right now. It's called the Great Equation. A lot of people will say, well, in order to decrease encounters, you want to make people healthy. And in order to make people healthy, you've got to give them medical care. And in order to give them medical care, you have to increase access to care. And that equation is wrong, and I'm going to tell you why that is. You would think that it's right, because you would think that access to medical care would make people healthier, and that would help us to over the long haul, control encounters like we're going to have to do. Well, 2 reasons why that doesn't work right now. Number 1, our current system is very, very bad at coordinating care. And I'll get to a couple slides in a little bit. Now, I told you, I just want to stop right here a little bit, because I told you how well we do at rescue care compared to other countries. You know, we're good at heart attacks, we're good at strokes, we're good at cancer, do good at transplants compared to like European countries, and I showed you those graphs at the beginning. What those countries do better than us is this. They actually are better at coordinating care than we are, at regionally sort of thinking about primary care, preventive care. They do that better than we do. Almost every other country that practices Western-style medicine, Canada, Europe, New Zealand, Australia, Japan, they do better at primary care and coordination of care than we do. So we're good at certain things, and they're good at certain things. Nobody's good at everything, and the cost for everybody keeps going up and up and up. I mean, that's the bottom line. I want to concentrate, though, on that bottom line right there. Our current system is not designed to change behavior. Here's an interesting slide. This is from McGinnis, published in the Journal of the American Medical Association first in 1993. What is the contribution of various factors to total health? Okay. And this is what the literature shows. Your behavior accounts for about 40% of your total health. If you smoke, if you drink too much, if you don't get any exercise, sexually transmitted disease, unwed teenage pregnancy, other things like that, you know, there's not going to be a lot the healthcare system can do for you over the long haul if you don't take care of yourself, all right? Next thing is genetics. Genetics is about 30% of your total health. Just nothing any of us can do about our genetics. If you have the wrong genetics, no matter how well you take care of yourself, you still may have a heart attack by the time you're 42. If you have really bad genetics for the heart. 20% is environment and public health. And then in the bottom there, only 10% of the delivery of health care, the Loma Lindas of this world and other hospital systems and so on, is actually healthcare delivery. So this great equation right there, no, really, not really, at least not yet. So let's move on then. How are we going to do that? How are we actually in the world to come going to control encounters? Because we're going to want less encounters. Right now I want more encounters. I want more admissions to Loma Linda. That's how we make money. But in 5 years, I probably will be trying to do the opposite. How would we do that? So now I'm going to tell you everything you need to know about population health in about 10 minutes. And you're going to know more about population health than 99% of physicians out there because they don't get this training in medical school at all. People who do well at population health have found out a couple of things. Number one, it's not just a population. When you look at the population of San Bernardino, from a healthcare perspective, it's not just a single population. It's strata of populations. And what most people do is they divide it into 3 strata, if you will, or 3 different subpopulations. We'll call the highest one about 5% of people, the sickest of the sick, the high-risk patients at the tip of that triangle there. We'll call the next one the rising risk patients. And what's important about the rising risk patients is that 18% of them go into that top category per year. And then the bottom ones are the low-risk patients, usually young, very few conditions, if any at all. Let's take these one at a time. I mentioned this already, the 600-pound gorilla. If you take the top 5%, you will find that Medicare spending, or spending of any payer, is highly concentrated on this top 5%. The top 5% sickest of the sick. We know at Loma Linda, for instance, we have 26,000 people that are self-insured. We insure our employees, and we insure our docs and so on and so forth. We're all self-insured. We have our own insurance company for that at Loma Linda. The top 5% of our utilizers utilize 46% of the dollars. And that's very consistent. Here, this is 2005 data from the Congressional Budget Office. The top 5% of utilizers in Medicare use 43% of the dollars. Look at that. The top 25%, bottom right there, use 85% of the dollars. Now, why is that? Why do those people soak up such an inordinate amount of the dollars? Well, it's right here. The usual high-risk patient looks something like this. This is their profile. Chronic illness is the big thing. There's about 7 or 8 illnesses, and again, this is usually due to how people take care of themselves. It has to do with smoking, it has to do with drinking, not getting enough exercise, but sometimes you can just have bad genetics. Sometimes you can do all the right things and you get some bad genetics in there, but for the most part, it's how people take care of themselves. So they've smoked and they've gotten obese over the years, and the next thing you know, they've got emphysema, and then they have a heart attack and they have heart failure, and now they've got diabetes because they're overweight. And then they have psychological needs because they get depressed from all of that, and then they find out that they can't drive anymore because their diabetes has hurt their eyesight and so on and so forth. Now these patients are amazingly complex. In order to treat them, you have to have a lot of management resources. Those management resources are listed not in complete form in the upper right-hand corner. And here's the problem with the healthcare system as it's currently construed. We expect these people, elderly, mentation isn't just right, supremely complex, to manage themselves, and they can't. It's too complicated, okay? So organizations that have made a dent in the cost of these top 5%, what do? They coordinate the care, okay? They coordinate the care. They help these people to maneuver through a very complex healthcare system, and that's how you do the top 5%. Now let's go to the next ones down. That is the rising risk patients. The goal here is to decrease that 18%. Okay, you want to make it so that less people go to that high risk on a yearly basis. And organizations that have done that have found that you have to look for risk factors. All right? Now, the people in that rising risk population, they may have 1 or 2 chronic illnesses. They may have had a heart attack and have mild congestive heart failure. I just hit my microphone. I saw 3 people jump. Sorry about that. All right? They may have 1 or 2 chronic diseases, but they don't have a lot of chronic diseases. They don't have like 5 or 6 like the high-risk people do. They have 1 or 2 maybe. But the thing that they do have is multiple risk factors. Look at the risk factors there. They are obese. They are depressed. They have high blood pressure. they're stressed out, they have a poor diet, they're unemployed. Those are all risk factors. And in order to keep the people in the rising risk population from becoming high-risk populations, you have to mitigate those risks, all right? And it's a different approach. It's not so much care management. It's something that we call the medical home. Different approach than the people in the high risk. Don't have time to get into details. All you need to know, it's a different approach. You're stratifying the risk into 3 different strata, and then you're throwing different resources at each of those strata. That's the whole point. Those are the 2 things. Let's go to the 3rd one right now. These are the low-risk patients right here. These are young people that don't think they'll ever get sick, for the most part. The essential thing here is to attract them and retain them. And how do you retain them? They love their electronic portals. These are the people that want to take care, want their health care via some sort of an electronic pathway. They don't want to have to go to a doctor's office once a year. They don't want to have to go to the ED when, they want other ways of accessing health care. So again, a very different approach. So when you look at it all, the high-risk patients, 5% of them, care coordination. The rising risk patients, behavior change. You want to get those risk factors and mitigate those risk factors that will take them to high risk if they're not mitigated. The low risk patients, find them and keep them. They're young. Go after what the young like. All right? So that's what we're going to be having to do in the next several years when it comes to encounters, trying to control encounters into the healthcare system. Now what about after somebody does encounter the healthcare system? Let's say that somebody comes to Loma Linda, they have pneumonia and they're admitted. So that's an encounter. Their admission counts as an encounter. Now they're in our system. What happens then? Well, this is where we get into processes per encounter. What on earth is a process? Well, let's look there in the middle. Process has 3 things. It has an input, has something you do to that input, and then it has an output. So let me describe that. I used to run the laboratory at Loma Linda. I ran it for 16 years, so I know a lot about the lab, and I'll tell you what I mean by that. Doctor sees a patient. They write orders for blood work. And let's say they write something called a complete blood count. So they stick a needle in somebody's arm. They bring this tube of blood to the lab. All right, somebody does. Usually comes through a pneumatic tube. So it comes to the lab. That's the input to the lab. It's a tube of blood. Then the lab knows exactly what it's supposed to do. It does that. That's the process of the work that they do on the blood. And then the output is information about that blood. So the input is the tube. Process is within the lab, and the output is information. That is a process. All work is done in a process. Okay, so what kinds of processes are there in hospitals? Well, you can think of the hospital as one big process. The patient comes in one side, a bunch of stuff happens in process, and then the patient hopefully comes out the other side better off. There's a bunch of sub-processes. So I described the lab. But medication orders in the pharmacy, that's a sub-process. Radiation orders in a radiology. It could be orders for dietary in the dietetics department, et cetera, et cetera, et cetera. All these processes. Now here's the kicker. Who controls utilization of processes? Who controls how many processes that get kicked off on a patient during a particular encounter? It's 100% under the control of physicians. Because nothing happens unless a physician writes an order. These processes don't happen unless a physician writes an order. So I tell my physician friends when I'm talking to them about this stuff, if you think hospitals can control costs without you in the future, look at this ratio. You're dreaming. You drive 70% of their resource utilization with your pen. Okay, 70%. That's the number that's out there. Maybe it's 60, maybe it's 80, I don't know, but it's high. Whatever it is, it's high. So how are you going to do that? Boy, if you start talking to doctors about controlling utilization, you get mad doctors. They hate it when they lose their autonomy. Now, I am one, so I can talk about them like I'm going to talk about them. And that is to say, they're going to have to get over that, but there are parameters there. Let's ask a question that I sort of alluded to before when it comes to all this variation. I told you that there's a lot of variation in the way that doctors practice medicine. They don't all do it the same way. You take a pneumonia patient and have 5 different doctors do work on a pneumonia patient, you'll probably find 5 different ways of treating that pneumonia patient. Really, truly. And that's true all across a lot of the things we do in healthcare. And we talked about why there's so much of that variation. We talked about why that variation is bad. Now let's talk a little bit about what can we do about it. Okay, and this is an important thing right here. There's 2 types of variation. There's what I call a good variation and there's bad variation. The good variation is also probably better termed unavoidable variation. That's the variation that we as human beings, as biologic systems have. Biologic systems vary. They vary a lot, just naturally, they do. Physiologically, we vary. Genetically, we vary. Socially, we vary. We all have different social circumstances. Psychologically, we vary, depending on lots of different things. We have different spiritual values. That's the kind of variation that's within a human being. You can't control that, okay? You can't control that out. That's just there. A hospital or any healthcare provider has to be flexible to handle all that variation. That's the good variation. But then there's the bad variation. This is what I call professional variation. Patient comes in, needs a hip replacement, and doctor who says, well, I trained at Mayo Clinic. This is the way we do hips at Mayo Clinic. Another guy says, well, I trained at Cleveland Clinic. We do it different, implying, of course, that we do it better. You got another guy who says, well, Sonny, I've been practicing here for 37 years, and let me tell you how I do it, and I never have trouble. Well, who's right? Well, nobody knows because there's no data. Right? That's what I call professional variation. Everybody does it different, and they all think they're right, but none of them have data to prove whether they're right one way or another. Okay? What we need to try and do going forward is to decrease that professional variation while maintaining the flexibility to handle the unavoidable variation or the good variation that naturally comes with patients. And once physicians understand that difference, at least in my experience, they actually get a little bit more open to it. The last thing we're going to talk about here is cost per process. So once the physician writes the order and launches the process, there's a cost associated with carrying out that process. This is an interesting ratio because this is the one that's usually under, the only one of these ratios that's under the complete control of the provider entity. So let's say Loma Linda University Medical Center. They control the cost per process. Why? Because they own the buildings, they hire the people, and they buy the materials that are used in that process. So they really control that ratio right there. Loma Linda does. They don't control processes per encounter because docs can control that, and encounters per year, of course, that's a population thing. So Loma Linda doesn't control that, but they control that last ratio. So when a hospital or a healthcare provider, when the budget gets tight and they're trying to make budget, what do they traditionally do within that ratio? What do they lay people off, right? That's been the time-tested thing. Let's lay people off. That's easy to do. Or let's squeeze the vendor and see if we can decrease the prices of the things that we're buying, you know. And that has worked a lot in the past, especially in the short term. I mean, you lay people off and then it creeps back up over time. You know, you decrease vendor prices and they creep back up over time. But it's at least worked in the short term to meet a budget. But it's not going to work in the long term. It's not going to work in the capitated world that we're on our way to. That just won't cut it. It won't even get us 20% of the way where we need to go. It's going to be a lot of thinking out of the box, you know, bend the labor cost curve, redesign how we take care of patients, develop a culture of constant improvement that actually pulls out what is a tremendous amount of waste in healthcare. Tremendous amount of waste in healthcare. Make no mistake, that's another lecture. So in short summary of what we've talked about today and trying to get you out of here on time, yes, modern medicine is the best the world has ever seen. I would certainly rather have my MI in the US than anywhere else in the world, but it does cost too much. And of all the things that contribute to that, I talked about practice variation. We hit a lot today on practice variation. PPACA is trying to fix all this. PPACA was insurance reform, remember, came out in 2010. But then this shared savings legislation came out in 2012. That's a whole lot more aimed at controlling cost, and it's causing us to turn backflips. Will ultimately take us, I think, to capitated healthcare. And the financial challenges, revenues down, costs are up, and the aging population is basically playing havoc with our payer mix and our case mix. And last but not least, the measurably better outcomes for measurably less dollars. We're going to have to control our encounters in the world that we're coming to, the population health. We're going to have to look at how process utilization, our cost control per process, et cetera. So, bottom line, better outcomes at a lot less cost. And when I give this lecture to healthcare workers, they look at me funny, and they say, we're not going to be able to do this. No one can do this. It's never been done. It cannot be done. So I throw up this slide right here. My second to the last slide, the Wall Street Journal, Perverse Incentives in Healthcare, 2007. I don't know who John Goodman is, but I like the quote. Research at Dartmouth Medical School suggests, I'm going to read this to you. I don't like reading things to people, but I have to read this one, that if everyone in America went to the Mayo Clinic, our annual healthcare costs would be 25% less and we'd get better outcomes. If everyone in the United States went to Intermountain Health, I mentioned that's the one in Utah, I mentioned it briefly before. It's a very highly respected organization. In Salt Lake City, our healthcare costs would be lowered by 1/3. Now I'll move to the right. He says, why doesn't everybody do what those two organizations do? And he says, the answer is that high quality, low cost care is not financially rewarding. Indeed, the opposite is true. Hospitals and doctors can make more money providing inefficient, mediocre care. I find that insulting, and I could give a whole lecture on that because I don't think that that's true, but I want to concentrate on the left side of this particular document here, on that first thing about Mayo and Intermountain Health. It is possible to do better health care for less money. It is absolutely possible. It's being done in certain institutions around the country. And the rest of us are going to have to emulate that. The thing is that it's really, really hard to do. And it involves a lot of leadership and a lot of paradigm shift. But better has no limits. All right? I actually think that you can frame this as a risk or you can frame it as an opportunity. It is a risk for organizations that don't own up to what's going to happen and don't respond. They will not survive. They will go broke. Okay? They will get swallowed or they will go broke. But for organizations that do know what's going on and prepare, it gives us some incentives to do some things we haven't been able to do in the past. I like the idea of trying to make a population healthier. I like the idea of trying to affect San Bernardino County's poor and so on in ways that we haven't been able to do before because we were never incentivized to do it under the old system. There's a lot to like here, but it does have its challenges. So with that, I am done. If there's questions, comments, rumor, or gossip, I can stick around a while. Thank you all, and have a good lunch.